Our next presenter today is Mary Jane Voss. She is a dietitian in Minneapolis, Minnesota at the University of Minnesota Masonic Children's Hospital. She completed her undergraduate degree at St. Catherine University in St. Paul, Minnesota, and dietetic internship at the University of Virginia Health System internship. She is currently pursuing her graduate degree at the University of Wisconsin in clinical nutrition. She has been a part of the muscular dystrophy interdisciplinary team at the University of Minnesota for nearly 2 years. Her favorite part of working with families in clinic is building relationships with patients and caregivers and collaborating with families to meet nutrition needs and growth goals. Today, she will be presenting on nutrition considerations with muscular dystrophy with a deeper dive into limb-girdle muscular dystrophy. Thank you so much for joining us today, Mary Jane.
Hi, thank you so much for having me.
I will stop my share and I will allow you to share your screen.
Perfect. Alrighty. Awesome. So as Michelle mentioned, thank you so much for that introduction, allowing me to come in today. I have been a dietitian working in muscular dystrophy here at the University of Minnesota, going on 2 years now. And I really enjoy working with this population. It's been an exciting time to be a part of this practice area in nutrition, especially with the rapidly changing approaches to treatment, with advancements in therapies and their impacts on disease outcome and especially nutritional needs as well. I was very excited to learn about this opportunity since I enjoy diving into the research and learning more about best practice guidelines and areas. Limb-girdle nutrition is an area that is not super highly researched, nor are there published sound nutrition recommendations based on research easy to come by, which can make it challenging to navigate the information. So putting this presentation together, I was challenged to think about what we know about muscular dystrophy and best practice within the disease state as a whole, and how to apply this information when treating and considering the nutrition needs for limb-girdle. I think this is a great opportunity to talk and then discuss about what we do know and then what is not fully known yet, and how to best meet our nutrition needs with limb-girdle with the information we do have. Okay. So to start off, I do not have any financial disclosures or conflicts of interest with the presented material in this webinar. And my objectives for the presentation today are included here. The first is to understand the basic medical nutrition therapy of muscular dystrophy as a whole in order to lay the groundwork of knowledge for limb-girdle nutrition. So we'll start through just going through the medical nutrition therapy of muscular dystrophy and discuss potential nutrition risks to be aware of with muscular dystrophy and limb-girdle. Finally, there is limited research and recommendations on limb-girdle and nutrition, which can make it challenging to navigate information online. So to wrap up the talk today, I wanted to highlight some nutrition research that is out there on muscular dystrophy and their nutrition recommendations, while also identifying some common myths that can be out there on the internet and how to discuss them with your care team and in practice. Okay, so here's the roadmap for our presentation today. We will explore nutritional goals of care and the role of your dietitian on the medical team and the nutrition assessment in your care. We will walk through the components of the nutrition care plan and discuss the important highlights of each. Then discuss the life events and nutritional risks that accompany muscular dystrophy and may be seen in limb-girdle, and then wrap up with discussing nutritional myths found on limb-girdle and counseling topics to consider, and then wrapping up with opportunities for further research given the limited research that we do have. So to start, here are the general goals of the dietitian when providing nutrition therapy for patients with muscular dystrophy. And I think they're good for, the medical team and patients and families to be aware of. And these are a good starting place for your dietitian in their care on your team. So the first is to ensure patients are meeting their calorie, protein, fluid, and vitamin and mineral needs through their diet, whether that's through oral intake or through nutrition support. Ensuring patients are meeting their estimated needs can promote age-appropriate growth in kids, along with a healthy weight maintenance in the adult population, while managing the long-term risks that can accompany muscular dystrophy. The other two goals of medical nutrition therapy would be to prevent obesity and malnutrition, which are the two extremes of weight management. There are periods in the progression of muscular dystrophy through the life cycle that may put patients more at risk for either rapid weight loss and risk for malnutrition, or rapid weight gain with the risk for obesity. We can discuss these progression states and appropriate interventions later on in the presentation. All right, so the dietitian remains a vital member of the interdisciplinary team to provide nutrition care that is comprehensive and a care plan for families and the team. The 2018 Duchenne Muscular Dystrophy Care Considerations includes the critical recommendation for a registered dietitian to be a member of the care team. And they also highlight the importance of the frequency of visits and components of a nutrition assessment that should be included. These guidelines and care considerations recommend that a dietitian complete an initial nutrition assessment at the time of diagnosis or shortly thereafter, with reassessments spread out throughout the duration of life. They do not necessarily give recommendations on the frequency of follow-up, and care teams can determine appropriate intervals based off of the type of muscular dystrophy and nutritional considerations a particular patient may be at risk for. For example, in my practice, I attempt to see patients who have spinal muscular atrophy, who are dependent on a feeding tube at least at a minimum every 6 months, ideally every 3 months when they come in. While patients with Duchenne muscular dystrophy who are oral eaters, I may see on an annual or semi-annual basis, pending their nutritional risks. Listed here are the components of a nutrition assessment a dietitian include. They include the interpretation of anthropometrics, the review of their medical history and laboratory assessments, review of their diet history, which could include their daily intake, any supplements that they're on, and any allergies or components of their diet that might be indicative of allergies or intolerances, review of their intake in comparison to their estimated needs, review of their current medications and any impact that may have on your dietary intake, any gastrointestinal symptoms that you may be having, changes in chewing and swallowing function, any changes in ambulation status, and any psychosocial issues at home. So let's take a look at these components and discuss recommendations for muscular dystrophy and limb-girdle from the literature. So accurate anthropometric trends is crucial in the nutrition assessment for muscular dystrophy. Consistent weight and heights should be obtained at visits to allow for long-term tracking of nutrition status. Although anthropometrics remains an important part of the assessment, this can have some limitations in obtaining and interpreting the measurements, which I've included here. So those challenges, the first one would be, that standard growth charts, especially in pediatrics, and the use of the BMI do not take into consideration changes in body composition that we see in muscular dystrophy with the progressive loss of muscle mass and the ability to differentiate in fat mass versus muscle mass is challenging to do with the standard BMI calculation. There also are not standard growth charts developed for limb-girdle to assess growth within the cohort of the limb-girdle disease state. Duchenne's muscular dystrophy does have a specialty growth chart. It's not always used in practice, or in the nutrition assessment, but it is out there. And so other types of muscular dystrophy like limb-girdle, this does not exist and could be an opportunity for research and a more comprehensive nutrition assessment. Finally, the ability to obtain measurements on non-ambulatory patients, patients with limited ranges of motion, patients with joint constrictures, and patients with scoliosis can make it challenging to obtain accurate measurements. All right, so how are we going to overcome these anthropometric challenges? I think that a lot of clinics and patients and families face this within the muscular dystrophy population, especially in clinics and care teams that may not have specialized training across all of their staff. At our clinic, I often face inconsistent measuring methods across staff, lack of denotation of the type of measurement, especially in linear measure, whether we're using a length board, the patient was standing, or if it was a measured arm span, which can make assessment of these trends challenging, especially if we're changing between visits and type of measurement. So I often emphasize with the medical team and families who may be doing home measures, the importance of assessing weight over time can show trends. So taking into consideration weight trends alongside other assessment information can give us a bigger picture of changes in anthropometrics. Other information that would be vital could include changes in your medical history, your ambulation status, nutritional intake. So if that has changed at all, or any GI symptoms you may be experiencing that could be suggestive of absorptive issues as well. So those alongside of our weight trends can kind of give us a bigger picture when linear measures can be more challenging to obtain. It's also important to have appropriate measuring methods that are consistent across height and weight and ambulation status. For non-ambulatory patients, the use of a Hoyer scale allows for accurate measures while keeping the patient comfortable. In addition, for non-ambulatory patients, the use of standard linear measure would be important as well. An alternative measure for non-ambulatory patients often cited in the literature is the use of individual segmental measures, which involves the measure of different parts of the body and then comparing that to the standard population. So this is often used in cerebral palsy and requires some appropriate training and then also some calculations alongside of it. I've often seen in scoliosis and in muscular dystrophy the assessment of arm span for tracking of linear trends, although research is conclusive that there can be some discrepancies between linear measure and arm span, making it not the most reliable measure unless we're looking at overall trends over time. Finally, when combating the BMI challenge with changes in body composition, the use of a nutrition-focused physical exam administered by a registered dietitian can help with assessing the changes in muscle mass and fat stores to assess like body composition changes over time and lend additional information to our nutrition assessment. So another nutritional consideration would be the use of laboratory evaluations. There are a few labs to keep in mind when considering nutrition status. Laboratory data should be obtained on a regular interval to assess long-term trends of nutrition and health. So listed here are some suggested laboratory draws to monitor. The metabolic panel and the fasting lipid panel and then iron studies are good to monitor just overall general liver, kidney, and general health. And they can give us some indication as well to nutrition status. Labs should be checked and evaluated on an annual basis. And research in muscular dystrophy and the Girdle has shown the importance of bone health over time with the progression of the disease. So calcium and vitamin D should also be monitored annually for overall bone health and supplemented as indicated by the labs. Calcium and vitamin D levels alongside a detailed diet history of calcium intake can assess the adequacy of our calcium intake from our diet for our bone health. If calcium intake is below the recommended dietary allowance or the RDA for age for the patient, the team should start supplementation to continue to promote bone health, which we can talk about in a minute here. So the diet history remains an integral part of a nutrition assessment and provides the bulk of the information on daily intake and any changes since you have last seen a registered dietitian. There are many different ways that dietitians can obtain a diet history. And so I feel like the top three generally are, the first is like a 24-hour dietary recall. So foods that were consumed in the last 24 hours can give a picture of what foods, like a typical intake can look like. Your dietitian may ask you to keep a 7-day food log prior to your visit to look at a more comprehensive picture across a 7-day week to look at the intake. Now this can be a little bit more labor intensive, but can lend good information to like an average of calorie intake or protein intake, and reviewing it during your visit can be really helpful and provide a lot of data. There's also a questionnaire called a food frequency questionnaire that your clinician may ask you to fill out that may ask about the frequency of how often do you consume lean proteins, or how often do you consume whole grains? And it can say daily, multiple times a day, never, sometimes. And so this can give an idea of the different types of food that you may be consuming and how often you're consuming them throughout the week. There are a variety of tools to determine these nutrition histories, and clinicians can decide which they prefer within their clinical setting. And they have all kinds of pros, cons, and limitations that come with each. When selecting methods of gathering information, some questions that dietitians should consider asking when it comes to muscular dystrophy would be the timing of meals. So what time of the day are you having your meals? Timing of snacks. What are your portion sizes look like at meals? Do you finish 50% of what's on your plate? How do your portion sizes compare to other people who you may be at the table eating with, or your caregivers? Have there been any changes in intake since your last nutrition assessment? It can also be good to screen for food insecurity and ability to obtain food for the home, to identify any barriers that patients and families may be having, and connecting them with community resources can be huge. And then any concerns that families or patients may have in the ability to prepare food at home due to changes in functional status. It can be good to assess the variety in the diet, especially in regards to proteins, fruits, and vegetables. In addition, what calcium sources are included in the diet to promote bone health? Are we using dairy sources such as milk, yogurts, cheeses, things like that? Or if we're not using those, are we using non-calcium dairy sources and trying to get 2 or 3 servings per day? And then any signs or symptoms of allergies or intolerances. And then finally, in the diet history, I also like to include any review of medications that are currently ordered, including nutrition supplements like a multivitamin or maybe a vitamin D supplement. Are we taking it consistently? And any over-the-counter supplements that clinic or families or patients may have added, whether that's an additional vitamin or mineral or maybe an herbal supplement that they may have started. So let's talk a little bit more here about the evidence for supplementation. Pending the findings of your diet history, you may find the need for additional supplementation in addition to the diet. Things that could impact that might be the calorie intake or nutrient density of the diet. So how many fruits and vegetables are we getting in? Are we meeting our protein needs? The patient may need to start a multivitamin. I generally like to try and meet our needs by mouth first with foods. But sometimes a multivitamin can help alleviate some concerns for maybe, deficiencies. And so that can be good to discuss with your medical team. The next concern you may have would be the calcium intake of the diet. As discussed earlier, based off of those 2018 Duchenne care considerations, vitamin D and calcium are part of those annual labs to check bone health. Pending levels, supplementation may be recommended if your calcium intake is less than the recommended dietary allowance for age, or if vitamin D is below 30 nanograms per milliliter. Very little research has been posted on the use of amino acids and herbal supplements, although the use for supplements in this patient population with muscular dystrophy, when surveyed in research, has been upwards of 65%. So the research is limited, although in practice, a lot of times patients are using these at home. There is some research that is limited in the use of coenzyme Q10, green tea extract, resveratrol, glutamine, creatine, and protandim for muscle cell function. So recommendations remain limited and should be evaluated with the assistance of a dietitian and the medical team, alongside review of the efficacy and safety of any other supplements, vitamin, mineral, or herbal that patients may have questions about. Okay, so now let's talk about macronutrients, so calories and protein needs. So when considering the estimated needs for limb-girdle muscular dystrophy, there was actually a study done way back in 1992 looking at the energy and protein needs for different types of muscular dystrophy, which included limb-girdle. While this study was conducted 20 years ago, it is the most up-to-date information I was able to locate with the limited research out there on the nutrition needs for limb-girdle in regards to calories and protein needs. This research was conducted in Japan, and the goal of their study was to determine if weight loss and muscular dystrophy was due to either reduced calorie intake over time versus an abnormal energy expenditure. So maybe needs were higher than that of the general population. The two types of muscular dystrophy that they looked at was first Duchenne, with their sample size was about 310 patients, so a pretty generous sample size. And then they also had patients with limb-girdle included, and their sample size for limb-girdle was 28 patients, so a smaller sample size, which could be a limitation in the interpretation of these findings, in addition to the age of the study. So given this limited research available, I based these estimated needs off of this study in combination just with general practice within limb-girdle and what we know. Okay, so overall, their findings were that the basal metabolic rate, or the calorie needs over a 24-hour period that was burned by the body, was close to that of the control group. So they did not find suggestive evidence of hypermetabolism or a higher calorie need for patients with Duchenne or limb-girdle muscular dystrophy. Given these findings, the use of calculations for the basal metabolic rate with an activity factor would be appropriate to determine estimated calorie needs. So the study found that 30 calories per kilogram of body weight was the estimated calorie needs to maintain the weight for an adult patient with limb-girdle muscular dystrophy. Given the needs of limb-girdle is close to that of the control group, the following calculations could be used. Okay, so in pediatrics, the basal metabolic rate can be calculated using the Schofield equation with an activity factor pending ambulation and activity status. In the adult population, we like to use the Harris-Benedict equation with an activity factor as well, pending ambulation and activity status as well. Now, we talked about before the limitations for anthropometric measurements, especially with linear measure being challenging. So the Schofield equation and the Harris-Benedict require an up-to-date height and weight to determine the calculation and the estimated needs. So there are some measurements or recommendations out there that we don't necessarily need an updated linear measurement for, we just need an updated weight. And so when there are challenges or we question like the accuracy of a linear measure, we could use these. So the World Health Organization has one for kids that measures your resting energy expenditure, and you could use an activity factor for this as well. In adults, as a result of that study that I referenced, the Okada study, and just general adult recommendations, the general recommendation of 25 to 30 calories per kilo of body weight could be a good place to start, and needs could be adjusted pending your weight trends and your goals. I've included over the next 3 slides, we won't kind of get into the weeds of calculations, but I've included the equations for reference along with some general activity factors to consider. So the first one here is that Schofield equation. It's split up by age here on the slides. And these you require the accurate height and weight. For an activity factor, I generally use 1.2 for non-ambulatory patients at a stable weight. If ambulatory and having a stable weight, 1.3 could be considered. If you have concerns for being like their weight is under where it should be, or they need some catch-up growth, or maybe they have really high activity levels, you could go up to 1.5. So you would calculate their estimated needs using this equation and then multiply it by either 1.2 or 1.3 or 1.5 to kind of get their estimated needs to take into consideration their activity level. Okay, and so here is the Harris-Benedict equation for the adult population. You could use the 1.2 to 1.3 here for your activity factor. And then here is the World Health Organization resting energy expenditure equation that you can use when there isn't necessarily an accurate length or length is challenging to obtain, okay? And I would use the similar activity factor to the Schofield equation in the pediatric population with these as well. So you would use this weight here to obtain it and then multiply it. Okay. All right. Now let's talk a little bit about protein needs. When we look at protein needs for this population, we're going to go back to that study that I referenced from 1992. They found that the minimum protein needs for maintenance of nitrogen equilibrium, which is basically how much protein are we utilizing per day, was 0.84 grams of protein per kilogram of body weight in the adult population for limb-girdle. Okay. This finding demonstrated that the protein needs of patients with limb-girdle are similar to that of the general population with the recommended dietary allowance. So I included the table of the recommended dietary allowance here for you, split up by age and then gender. And I think in practice, families and clinicians can use this as a starting point for protein needs for both the pediatric and adult patients with limb-girdle. So this can be a good place to start, and working alongside your medical team to determine protein needs can be helpful. Okay. When considering fluid needs, there are a few ways to determine appropriate fluid needs. In practice, often clinicians will use the Holiday-Seeger method and reference here, especially for pediatrics. So it's based off of the patient's weight. And so how it's calculated is when your weight is below 10 kilograms or under like 22 pounds. So in small children, it's 100 milliliters per kilogram of body weight. Once you reach 10 kilograms of body weight, you switch then to it's 1,000 milliliters plus 50 milliliters per kilo of body weight over 10 kilos. So up to 20 kilos of body weight. Then once a patient is greater than 20 kilograms, it is the 1,500 milliliters from the first 20 kilos of body weight. And then you add 20 milliliters per kilo for every kilo over 20. This can be an easy incremental way to adjust minimum fluid needs when working with a clinician. Once a patient reaches adulthood though, or a patient may have an elevated weight where this method may over-calculate our fluid needs, 1 milliliter per calorie per day can be a quick estimate of fluid needs as well. Often this is a starting point for individuals to estimate their needs, and unless they're on tube feeds and you can very quickly calculate their exact fluid that they're getting, the true intake of fluids can be hard to quantify and vary day to day. So often it can be good to just kind of discuss general hydration status, frequency of urination, and indications of hydration. So like dryness of skin or mucous membranes from a nutrition-focused physical exam with a dietitian. And that can lend to giving recommendations on any changes that you should be making to fluid intake. All right. Now, there are a few GI or gastrointestinal symptoms that accompany muscular dystrophy that individuals with muscular dystrophy can be at higher risk for. So I just wanted to highlight 3 of those here. The first one would be constipation. This is a common GI complication with many forms of muscular dystrophy, including limb-girdle. Some risk factors are highlighted here. First, we have with decrease in mobility or just general immobility with muscular dystrophy can lend to an increased risk for constipation. In addition to just changes in overall abdominal muscle weakness. With swallowing dysfunction, patients are at a higher risk for dehydration if they're unable to meet their fluid needs to maintain hydration by mouth. And so dehydration can also be a risk factor for constipation as well. Finally, generally, if the diet is just low in fiber, this can also lead to concerns with constipation. Treating your constipation should kind of assess the cause of the constipation. So there's a lot of risk factors and things that could be causing the constipation. And so trying to get to the root cause can be helpful. So patients with a low dietary fiber intake, it can be helpful to increase the fiber and the fluid to address constipation. So as we increase fiber in our diet, it's important to also increase our fluid intake to help with the clearance of that fiber. A patient may also be experiencing constipation due to changes in their swallow ability. So in this case, assessment with a speech-language pathologist of your swallow could be investigated and treated. And that may include modifying the consistency of fluids pending the findings of your swallow study, or use of free water if you have access to a feeding tube. Finally, clinicians may consider the use of osmotic laxatives to help alleviate constipation. So some examples here may be Miralax, milk of magnesia, or lactulose. Okay. Another gastrointestinal symptom accompanying muscular dystrophy would be delayed gastric emptying. The onset of this could manifest with like postprandial, so after your meal, abdominal pain, early satiety when eating, so just filling up quickly after you start eating. The prevalence of nausea or vomiting shortly after finishing a meal. If delayed gastric emptying is a concern, you may want to consider a gastric emptying study to be performed to determine the severity of delayed emptying. If present, there are a few treatment options available. From a nutrition standpoint, education just around low to moderate fat intake may be helpful. So just watching the portion sizes of healthy fats and considering limiting like fried foods and high fatty foods can be helpful, with a focus on discussing those portion sizes. In addition, just small, more frequent meals could be helpful to alleviate some of that early satiety and some relief of that abdominal pain, the nausea, or the vomiting. So decreasing your portion sizes, but increasing the frequency in which you're eating. So trying to eat every 2 or 3 hours, more smaller meal sizes can be helpful. Your medical team may also consider the use of prokinetic therapy to help with motility alongside those nutrition interventions for treatment. Finally, if delayed gastric emptying is very severe, the medical team could consider the use of feeding past the stomach into the small intestine using a post-pyloric feeding tube in very severe cases when these other interventions may not be providing relief of your symptoms. The final major GI symptom seen is reflux. This is more commonly seen in muscular dystrophy with a non-ambulatory status. There are a few risk factors with muscular dystrophy that can increase the prevalence of this reflux. These could include obesity or carrying excess weight, scoliosis, esophageal dysmotility, or that delayed gastric emptying can also contribute to reflux symptoms. As discussed with the delayed gastric emptying, these patients with reflux may benefit from small, more frequent meals to help manage these symptoms with a focus on moderate fat intake. When obesity is present, use of weight management, nutritional interventions may also help alleviate the symptoms over time. So education around age-appropriate portion sizes at meals with a focus on lean proteins, whole grains, and a variety of healthy fat sources. From a medical management standpoint, your team could consider the use of a proton pump inhibitor or histamine 2 receptor antagonist medication. The use of the proton pump inhibitor chronically over time should be monitored given its long-term risk and side effect for an increased risk for bone fractures. And as we discussed, bone health being so important with muscular dystrophy, this risk for osteoporosis and fractures should be monitored over time and general bone health when on these medications. All right. So now that we've covered the components of a nutrition assessment, and what they may entail or what you may encounter, let's take a look at a few life events that accompany muscular dystrophy and limb-girdle that may put patients at a higher nutrition risk. The first is the potential side effect that accompany the use of steroid medications to help with maintenance of muscle mass or maintenance of strength. As we know, steroids can cause an increase in appetite and therefore potential for an increased calorie intake in the diet. When steroids are being prescribed, it can be helpful to have a dietitian upfront discuss the potential side effects that individuals may see on these medications and discuss about just nutrition management of the side effects upfront through the use of maintaining adequate hydration, using high protein snacks to promote satiety, and then management of carbohydrate intake and discussion of appropriate portion sizes can be proactive. If a patient is already on these medications and weight management is becoming a concern, bringing the dietitian in can be helpful, and having them seen more frequently discuss small goals to work towards in regards to weight management over time can be helpful to manage those side effects. Another side effect to be aware of with steroid use is the potential for sodium and fluid retention. Assessment of sodium intake along with adequate hydration is important, and clinicians can assess for fluid status with the use of the nutrition-focused physical exam when assessing the changes in weight if fluid retention is suspected. With changes in loss and ambulation with the progression of muscular dystrophy, this can result in changes in those energy expenditures, kind of like what we talked about with the calculations. Those calorie needs are going to change, which may put patients at risk. So ongoing work with a physical therapist on adaptive physical activity can help with keeping up with exercise as able. With decreased energy expenditure, education on portion sizes is also important. The loss of ambulation may result in changes in body composition as well, including changes in muscle mass and changes in fat mass. With a nutrition assessment, BMI, like we discussed, can be an unreliable measure of weight status, and using that nutrition-focused physical exam alongside weight and BMI trends can give an idea to changes in composition. Finally, the last two over here on the right would be dysphagia onset and loss of ability and feeding skills due to progressive muscle weakness can increase your risk for unintentional weight loss and potentially malnutrition. So it's important to have a team of a speech language pathologist, an occupational therapist, and a dietitian on the team to ensure patients are meeting their needs in safe manners. And I want to take a little bit of a deeper look at the dysphagia and the feeding skills as well here. So with the progressive loss of swallow function seen in muscular dystrophy with dysphagia, we know this can be a progressive onset and may present with some symptoms such as difficulty chewing, slower ability to move the food or form like the bolus, which is the food in our mouth, from the back of our mouth to our esophagus, which can leave pharyngeal residue after the completion of our swallow. So often the presenting signs include patients taking longer to finish their meals, the occurrence of a choking event or fear of a choking event, or any difficulty we may have swallowing, so it may be uncomfortable. With dysphagia, there can be concerns for aspiration, choking, and then changes in those nutritional statuses, including the inability to meet our needs, which could result in weight loss or potentially dehydration. Then with progression of muscular dystrophy and the changes in muscle mass, patients are also at a risk for changes in strength and potentially the ability to feed self or prepare food. This decrease in strength along with the risk for dysphagia can put patients at that increased risk for weight loss, dehydration, and malnutrition. The involvement of a dietitian, speech language pathologist, and occupational therapist on the team can help to screen and treat onset of dysphagia or the decreased feeding skills early on. And then this team can also then provide appropriate education and interventions or modifications at that time. These these interventions or changes may involve modification of food textures or liquid thickening for a safe swallow, the use of the chin tuck maneuver in the case of dysphagia, environmental interventions to assist with feeding skills with the assistance of an occupational therapist can be helpful, along with potential use of oral nutrition supplements from a dietitian to meet needs. With progression of muscular dystrophy, your team could consider ongoing monitoring of the safety and swallow and feeding skills, and potential need for a feeding tube pending nutrition risks. In muscular dystrophy, especially this was highlighted in the 2018 Duchenne considerations, early discussion of the potential or anticipatory guidance on G-tube feeding is advised. Early discussions with a healthcare care team can familiarize patients and families with the idea of G-tube feeding should they become necessary. These discussions can be strictly proactive, so the use of nutrition support does not take clinicians or families by surprise should they become indicated. Indications could include dysphagia or inability to self-feed due to changes in muscle mass or strength. Referral for a swallow eval and optimization of nutrition is important. And diet texture modification or physical maneuvers may help with this risk. Alternative nutrition support, such as the use of a gastrostomy tube, could be considered if nutrition requirements cannot be met orally to minimize our risk for weight loss or malnutrition in order to help us meet our needs. All right. So now that we've reviewed the nutrition assessment components and considerations with muscular dystrophy and limb-girdle, where we're able to kind of discern information and recommendations, let's summarize some of the components of the nutrition care plan here put together by a registered dietitian. First, the plan should include the estimated energy needs and any changes or interventions being implemented to assist the patient in meeting their goals. Within their estimated needs, the dietitian can also include any changes in energy intake, such as the calories or the protein or micronutrient with supplementation. And education could be regarding portion sizes, protein needs, oral supplementation with nutrition supplements, vitamin or mineral supplements, or changes in nutrition support or fluid goals. Overall, the goals of care and nutrition plan should include how to meet our needs with any modifications to food textures as needed and overall promotion of a healthy, balanced diet. All right, so we've reviewed the nutrition assessment components and what they include and talked about potential nutrition risks we may face. Through reviewing the literature, there still remains many questions that families and clinicians may still have in regards to limb-girdle and nutrition, given the limited research and guidelines that are available. In this informational period of time that we live in, the internet remains full of information and recommendations that are always not always backed by research or science. So to prepare for this presentation, I took to the internet to see what information was out there. And I found a few myths out there that I thought were worth noting and discussing today. And some of these may hold partial truths to them on a situational level, while others are not true of limb-girdle nutrition. So let's just take a look and discuss these as they may come up in our clinical settings and practice. All right, so the first myth that I came across was that limb-girdle patients have a higher protein need than the average adult, and that a high protein diet is needed. Now, we already discussed the protein needs above for limb-girdle being closer to that of the recommended dietary allowance. And these are a good starting point for patients and clinicians in a nutrition assessment. The information online regarding exact protein needs remained vague from my reading without specific recommendations necessarily. And I often found that these recommendations were given to ensure that patients were meeting their protein needs, and also in regards to helping manage weight and protect muscle mass losses. In clinical practice, I think it is important to educate families on protein needs and the use of protein from a weight management standpoint to promote satiety. Rather than consuming large volumes of protein that ultimately could take a toll on our kidneys or be converted into storage and fat stores if not fully utilized, I think that individuals with limb-girdle can focus on spreading their protein out throughout the day to promote satiety and protect their muscle mass. Research has shown that protein metabolism and the body's ability to use protein for the protection of muscle mass and growth maxes out at about 20 grams of protein at any given meal or snack period. And that excess protein intake beyond 20 grams will often be converted into another energy form, such as glucose. Therefore, I often recommend that individuals can focus on ensuring that they get a good serving of protein with each meal to meet their estimated needs. And in addition, they may want to include a protein source with their snacks between meals for recovery if they're engaging in high physical activity levels, to promote satiety or the feeling of fullness if working on weight management goals, or to meet their protein needs if they're trying to do more small, frequent meals, if they're facing that early satiety, delayed gastric emptying, or reflux. All right. The second myth was that individuals with limb-girdle needed to avoid allergens, including, but not limited to, dairy, gluten, soy, food preservatives, artificial coloring, or other additives, and avoidance of foods that may cause respiratory or digestive problems. Now, there is no evidence in the literature to suggest that the consumption of highly allergenic foods in the limb-girdle population is indicated when allergies are not present. If there is a concern for allergies or food sensitivities, the involvement in workup with a gastroenterologist or allergy specialist would be helpful to assess for the need to eliminate certain foods from the diet. Elimination of unnecessary food groups may put individuals at risk for deficiencies in vitamins and minerals included in those food groups eliminated, or limiting the diet may make it more challenging to meet our calorie or protein needs. In regards to foods causing respiratory or digestive problems, the involvement of a speech-language pathologist to help with food modifications in texture or thickness of liquids can help with satiety of foods consumed in the presence of dysphagia when there is concern for foods causing respiratory or digestive problems. So this myth remains a little bit vague and may leave patients with unanswered questions. So the involvement with the speech-language pathologist, the dietitian, and potentially a gastroenterologist or allergy specialist can assist patients in determining necessary eliminations in the diet, but is not necessarily indicated across the board for all patients. All right, the third myth was the elimination of refined or processed carbohydrates, including breads, pastas, and foods with additive sugars included. The reason for this recommendation was a little unclear to me, and I think is speaking to the need for a healthy, well-rounded diet. Total elimination of processed gains is not necessarily necessary, but education surrounding appropriate portion sizes when it comes to these foods and the importance of including whole grains and fiber where able may be helpful in promoting a well-rounded diet with a variety of foods and carbohydrate sources. All right, the final myth was that individuals should avoid dry foods that may make it difficult to chew or swallow for patients with the onset of dysphagia or monitoring for risk to chewing or swallowing. This could become a true statement, and modification to these foods may be necessary under the guidance of a speech-language pathologist. As a blanket statement to muscular dystrophy patients without evidence of dysphagia onset, this statement may lead to a diet restrictive in food groups, putting patients at risk for deficiencies or inability to meet their needs. Concerns with the ability to chew or swallow should be brought to the attention of a medical team and addressed with the patient with appropriate interventions. So based on these myths and what we discussed today, what are some appropriate things to consider counseling on with families and ability to promote in our diet? To summarize, the key topics were, first and foremost, the importance and promotion of a well-rounded diet with a variety of foods within the diet. With the progression of limb-girdle, ongoing monitoring for feeding modifications or texture modifications as a team with your speech-language pathologist is important. In addition, collaboration with occupational therapy on feeding skills and food preparation at home can minimize nutrition risks. Overall bone health remains an important part of muscular dystrophy, and limb-girdle is monitoring intake and need for supplementation to promote bone health is important. Monitoring weight trends for risk for malnutrition and obesity is important, and counseling regarding portion sizes, adequate protein intake, fluid needs, the need for any nutrition supplements, and healthy snacks could come up. Finally, management of GI symptoms such as constipation, reflux, and delayed gastric emptying through nutrition interventions may include small frequent meals, limiting high-fat foods in the diet, increasing fiber and fluids in our diet. Okay, so I wanted to highlight just some good resources out there with all this information floating around on the internet that may not be reliable. What are some more reliable places we can turn for information? So the dietitian and medical team remain a great resource, first and foremost, for patients with nutrition questions in regards to muscular dystrophy and nutrition. Any concerns they may have or information on supplements or changes in their diet they may have on the internet from other patients or from concerned family members can be discussed for safety and efficacy for the patient with their medical team. In the world of online information, there are credible online resources patients can turn to as well for information regarding muscular dystrophy. The first online resource would be the Muscular Dystrophy Association website, which has great information regarding limb-girdle, the progression of the disease state, and management of symptoms, including general diet and exercise information. In addition, they also have a great summary of research, as discussed during the previous topic, talk on research being conducted in the world of limb-girdle muscular dystrophy. The next resource would be the CDC. I did find some free materials on muscular dystrophy, including limb-girdle management on their website, which I've included here for you to review. The Genetic Allowance website includes links and information for advocacy groups, opportunities for ongoing research, current endeavors in policymaking, free webinars, and new resources for individuals who are facing a new diagnosis or their families. And so these were some of those resources that I found online. So to wrap up this presentation, the few opportunities that I did come across that in preparing this from a nutrition standpoint that are opportunities for further research. The first would be that more recent studies than the 1992 study with a larger limb-girdle sample size would be helpful to assess estimated protein and calorie needs across all age groups. The studies looked strictly at adult and pediatric population, or adult population. So looking at the pediatric and adults with a larger sample size would be helpful. In addition, ongoing research into bone health and supplementation needs would be helpful for an area of research to consider. In my reading, I didn't necessarily come across exact calcium dosage when bone health is a concern. So looking into like baseline supplementation needs for those supplements would be helpful, in addition to ongoing supplement research. Finally, with the advancement in therapies for muscular dystrophy and progressional treatments and research in gene therapy and for different types of muscular dystrophy, I think ongoing nutrition research is needed for estimated nutrition needs and concerns following the treatment with these advanced therapies. Since these therapies remain a highly researched area and are becoming more commonly used, ongoing research just remains very important. So here are the references I included in the preparation of this presentation here, and some additional resources to consider for research. And so now I will open up to any questions that you guys may have. Thank you.
Thank you, Mary Jane.
Yeah.
We'd like to open the symposium to any questions the audience may have about nutrition. Like I mentioned before, you'll see the Q&A bubble on the bottom of your screen. Click on it and ask your question. You can also add it in the chat. I know that Mary Jane lives in Minnesota, but if you're looking for a nutritionist in your area, you can always contact the MDA Resource Center and they will find a nutritionist who is knowledgeable in neuromuscular disease in your area. So that option, or so that number and email is already in the chat. If you scroll up, you'll be able to see it. They are closed today, but they will be opening back up tomorrow, or not tomorrow, Monday. So we will wait a second as those questions come in.
Awesome.
We also had a webinar on nutrition last month.
Oh, awesome.
Yeah, and that was for neuromuscular disease as a whole.
Mhm.
So it kind of talked just about nutrition in general,
Yeah.
not as specific to limb-girdle, but that will be available to watch on demand soon, and that'll be on mda.org and on MDA's YouTube channel. And that one includes, you kind of talked about a little bit more about creating a diet specifically for, you know, your weight and body type, but they talked a little bit about the options. So what kind of proteins, what kind
Mhm.
of veggies. They also talked about barriers to eating. So maybe they don't have time to make food, or costs. So they talked a lot about
That's awesome.
things. Yeah.
Yeah, I think that, you know, there's so much information in the nutrition world. Like we could give like hour-long talks on those. So that's awesome. And
For
that's a
sure.
great resource for families and clinicians as well.
A question has come in. They want to know, what is the difference between a
Yeah,
micronutrient and a macronutrient?
great question. I think that a lot of times those can be, you know, thrown around terms. The way I like to explain it is a macronutrient is kind of a source of calories that comes from either protein, carbohydrates, or fats. So those are our major macronutrients. And so they contribute to that calorie intake. Now, a micronutrient is like those smaller nutrients, like vitamins and minerals, that don't contribute to our calorie intake, but we still need for other body functions that are important. So great question. Great clarification.
As we wait for some additional questions, I wanted to ask you how you have a conversation with a patient when it comes to, you know, tube feeding and that, like how does that conversation kind of start?
Yeah. I think it a lot of times depends on like both the age of the patient. So I mostly work in pediatrics. I have some adult patients, but I think a lot of times as a dietitian within our medical team, it starts with a conversation with the doctor or MD, just around general overall management and an option. It's an option for nutrition management, right? And so we like to lay the groundwork early on, either, you know, shortly after diagnosis or after that. It's not necessarily something that every patient faces, but it could be something that is a tool and a resource for families, especially when nutrition concerns and meeting needs can become stressful at home. Right? It can be challenging to meet needs. And a lot of times, you know, it can be a hard thing to come to terms with for the need for nutrition support. And so I think just ongoing conversations of the pros and cons, because every patient's going to be different too.
Right.
And how they want to manage their nutrition, and just knowing that it's an option for them. And, you know, some families, you know, pursue it because it can alleviate some of that stress. And, you know, I'm also happy to work alongside families where we want to continue to do everything we can to meet our needs by mouth as safely as possible. So in general,
Yes.
I see that here. Go ahead.
Yeah, what's the calorie difference needed between an ambulatory person versus non-ambulatory?
Great question. So when you go back and calculate those changes with like in pediatrics or using like that Harris Benedict. So when a dietitian kind of calculates your needs, it gives you a number based off of your weight, or like your weight and your height and your age. Okay. And so that activity factor that you multiply it by takes into consideration your activity. So your metabolic rate is just like to be awake and your basic function, right? And then to move around and exercise and do all of those activities of daily living. That's what is encompassed in that activity factor. So I would say in my practice, when I use those calculations in a pediatric patient, so in kids, that difference is anywhere from 100 to 200 calories, and in an adult where those needs might be greater, it's probably closer to 200 or 300 being those differences in ambulation or activity during the day. That's a great question. So generally that's what you see. A lot will depend on your weight status and what activities you are able to perform, but that's a great question.
Thank you. I just wanted to make a quick correction. The Resource Center can connect families to care centers who may have a nutritionist, or will be able to refer them to a nutritionist, not find them a nutritionist. So I just wanted to make sure that I clarified that before we moved on. I don't see any more questions in the chat. So Mary Jane, thank you so much for being here today. And thank you for all you do for the neuromuscular community. We really appreciate your support.
Yeah, thank you.